Hello, everybody. I would like to welcome you to this very interesting webinar on cervical cancer. It's the first webinar actually we've had on cervical cancer, so we're looking very much forward to it. And a very special welcome to Professor David Cibula. We are all very excited to listen to your presentation. And since Chalit is not here, we will not waste time on waiting for him to say anything. So, David, the word is yours. Thank you very much.
Thank you. And it's also exciting for me to have this opportunity. Let me try sharing my slides then. So as I said, it's also, but it's not easy for me. I know it because I used to have talks to primarily either medical students or physicians. But it was helpful for me to receive the questions from Verdi. Do I pronounce it well? No, you are mute, so I can't hear you.
I was muted. My name is Birte, but it doesn't matter.
Birte.
Yes.
Okay, Birte.
That's fine. I'll mute myself.
So I will follow it. I will give a sort of a brief update of the disease, and then we can discuss the details if you wish at any certain point. So this is a cervix, as a gynecologist can see it through the vagina, and this is a nice smooth cervix with the internal os here. And this is obviously another picture. This is already an awful tumor, which is obviously a cancer. We can see it's on a first glimpse. You see it's fragile. They are so-called atypical vessels, and it bleeds if you only touch it. So if we have any suspicion that there is a cancer, we have to very carefully assess, investigates the woman, although unless we cause a bleeding. So first of all, how frequent the disease is. Well, those are the trends. These red colors, and you have comparison of our gynae-oncology 3 diseases. So endometrial cancer, typically everywhere in the whole developed world. So in rich countries, it's rising since the most important risk criteria are obesity, a lot of stress, hypertension. So all diseases of a civilized world. Ovarian cancer, you see here, for some reason, and we are not exactly sure why this is the case in ovarian cancer, but within the last 10-15 years, the incidence is either flat or slightly decreasing. While in cervical cancer, it's going down. It's going down almost everywhere in the world. And if I said everywhere in the world, people usually think, this is only in Europe or in North America because we have very good screening. But in fact, if you see these curves, it goes down almost really everywhere. So even in Latin America, where the incidence is very high, even in Africa, there are some sort of screening mechanisms which tends to decrease the incidence of cervical cancer. Cervical cancer, amongst other malignant tumors, has a very special position for many reasons. And one of them is that there is the largest difference in the incidence if you take it globally. So on one hand, you have countries like Australia or Finland, where cervical cancer belongs to so-called rare diseases, rare cancers. So it's really very rare. And in other parts of the world, like Central Africa, it's still the most frequent cause of death among women. So it's very prevalent. Just a month ago, one colleague of mine came from a 1 month's visit to Malawi. He worked there in a hospital, especially focused on cervical cancer. and he saw like 50 cases per 1 week. So there are really patients queuing, and the number of surgeries, it's simple a question of the capacity of an operation theater. Otherwise, there are endless numbers of cases still. Even in Europe, the incidence varies quite significantly. So on one hand, as I said, there is still, missing Finland. So Finland is currently below 5 per 100,000. And on the other side, there are countries like Romania and Serbia, and probably also Russia. Although in Russia, we don't have really reliable sources of information, which is about 30. So it really varies dramatically. And this is also interesting, and it shows you age proportion, age difference in the incidence according to the stage of the disease. So here, this light blue color with a peak around 35 years, it stands for precancer lesions. So obviously, these CIN3 precancer lesions are very prevalent amongst young women between 25 to 35 years. This dark blue is stage 1. So obviously the peak is around the age of 35, and then it goes steeply down. But then there is the second age peak in the age of 65 to 70 years, and this applies mostly for advanced stages, for stage 3 and 4. And, all these women, in fact, are lost. We don't have still any curative treatment for these advanced stages. So all these women will inevitably die of the disease. And we will go back to the reasons, or to more details for the reasons for these different stage distribution in different age categories, when we will talk shortly about the screening. So screening is the method to find in the population or in the risk population either the cancer in early stages, which are still curative, so the patients can be definitely cured, or as in cervix, in pre-cancer stage, which is even more beneficial, of course, because the success of the cure is even much higher. And this is another specific feature of cervical cancer, that we don't only have an access to the cervix via vagina, we know pre-cancer stages. So we know that if we find such and such changes in the epithelium, those changes have very high risk of further progression into the cancer. But we even have so-called screening tests, meaning this is a cheap test which can be offered to either the whole population or to the risk group population. In cervical cancer, it can be offered to the whole population. And we have, in general, 2 histological types of cervical cancer. One is squamous cell cancer. The majority of cervical cancers are squamous cells. And this arises from the external part of the cervix. So the part which looks to the vagina. And then there is adenocancer, which grows from the internal os of the cervix. There are 2 different types of epithelium. And these adenocancers are, in general, more difficult to diagnose, more difficult to find, because they can be hidden inside of the cervix. So if you look to the cervix, as we do, gynecologists, the cervix seems to be okay, but the disease is hidden inside. And that's why if we take a sample, if we take a swab from a smear from the cervix, we take it both from external part, and then we should go internally to the cervical channel and take another sample from inside of the cervix. Here you see one of the reasons why still mortality in many countries, I'm not saying everywhere, because Finland, Australia are very successful, but in many even developed countries is higher than we would like to see. And this is because younger population is very well covered by the screening. But with advanced age, women stop going to be seen by gynecologists for multiple reasons. They think, they don't have sexual intercourse, they don't have more than one partner, they already delivered all the babies, so they don't have to go to gynecologists. But the coverage of the screening is getting obviously, very much down to an inadequate levels. So if you can remember, the second peak of the incidence was at the age of 65 to 70. And here the coverage, at least in the Czech Republic, is 30%. So obviously inadequate. And this causes these, advanced diseases, because usually these women are not seen by gynecologists for many years, for a long time, and they come only with symptomatic, so they already have symptoms, bleeding or pain, with advanced stages. This is another important message, which says that if you compare these two screening methods, which we have available currently, on one hand, cytology, which is older, more traditional, and HPV DNA testing, which is more modern and a new method, HPV DNA always win. So it has higher sensitivity. What it means that if there is a lesion, it's detected almost always by HPV DNA test, but there can be certain proportion of cytology which can be negative. So even if women, go frequently as recommended to gynecologists, they have their samples taken and sent. By only cytology, about 20 to 30% of lesions can be stayed non-diagnosed, undetected via screening. So the most sensitive is a combination of HPV DNA and cytology count. Why is it so that HPV DNA is so much better? Simply because cytology can detect the lesion only in this late phase, when already the epithelium was infected by HPV infection. It stays there for a long time, and this long time we count in many months, but rather years. It leads to transformation of the epithelium and dysregulation of the cells. And only at this stage, we can see the changes on a cytology. So the window which is left between the beginning of these changes and the cancer is quite narrow. While HPV infection finds the problem already at this stage, when the epithelium is infected by HPV virus. And we know that it will take, quite a long time before these high-grade changes will appear on the cervix. There is another, important message, because many women argue at us, at gynecologists, against vaccination currently, especially after, COVID and COVID vaccination. And all these discussions around it, and they say, why we should have HPV vaccination or vaccination against HPV infection if there is a screening. It's an alternative approach. So instead of being vaccinated and receive another virus, even if it's unaffected, we would rather go to regular screening. But it's not the same. The outcome of the screening, or the aim of the screening, is to detect these pre-cancer lesions. And if we detect precancer lesion, we don't have any good treatment. We don't have any pill or any local treatment. And the only possibility how to remove these changes is to remove part of the cervix. So it leads to a surgical procedure, which is called conization or cone. While in the vaccination case, a vaccination prevents infection. So it prevents everything. It prevents even the development of these high-grade lesions. So it prevents also a necessity of these surgical procedures. So it's a completely different story. And so far, there should be, a parallel screening and vaccination, because still vaccinated was only very young population, but it should be both. And if you count everything, what we have available in cervical cancer, that we have an access to the cervix, we know the precancer lesions, we have screening tests, which are very, very sensitive, very successful, very accurate, HPV DNA test especially. And we have on top of that vaccination, which prevents HPV infection. We have everything available simply to get rid of the disease as such. So any death of cervical cancer we consider as very and as unnecessary and very sad outcome, because it should have been completely prevented. And this is just to show you what means the cone, the conization, because a lot of women think it's a kind of minor procedure. My mother underwent it, and it's nothing. So this is the cervix, which is already exposed for the conization, and this is the conization. This is the principle of the procedure. The cone is usually 15 or 18 millimeter high, and if you consider that the length of the cervix in nulliparous women is about 3 centimeters. In fact, by doing it, we shorten the cervix by half. And, the miraculous part of women's body in terms of pregnancy is not the uterus itself, because it's just a muscle, and we are not surprised that the muscle can expand and can grow during the pregnancy. The miraculous is the cervix, because if we imagine that the cervix is creating a mechanism which remains, which first allows sperm to go from the vagina to the uterus, and then it stays closed during the whole pregnancy. And then at the end of the pregnancy, for some still unknown reasons, that it feels when the baby is mature, is ready to be delivered, and it starts to be softened, it opens, and it allows baby to be expelled. So for any pregnancy, the cervix is very much needed, and any shortening of the cervix causes high risk of pregnancy loss and premature delivery. So this is at the end of the conization. Then another topic is a clinical staging. In oncology, if we speak about staging, we usually mean the classification, which, as you know, can be either FIGO or TNM classification. But if we say clinical staging, we think about the combination of exams, which is recommended at the time of diagnosis for separately each cancer. And it's, of course, different from cancer to cancer. So according to international guidelines, clinical staging in cervical cancer contains, very simple exams. Besides gynecological examination, it's one of the 2 modern imaging methods, either MRI or expert ultrasound. And I like to say, because I'm proud of it, that the expert ultrasound is international guidelines thanks to the team from my institution, Daniela Fischerova and other colleagues. I remember that Daniela was really pioneer in that field. She started to use ultrasound in 2002, so 20 years ago. And thanks to a network of people and collaboration, they really proved and showed that ultrasound is equal to MRI in its accuracy, and in some aspect even better. So all patients with cervical cancer should be assessed either by MRI or expert ultrasound. And if on one of those techniques we see that it's more advanced disease, so large tumors, suspicious lymph nodes, suspicious metastasis, then the next step is also so-called distant staging. So one of the techniques which can detect lymph node metastasis and distant metastasis in the body, which is either CT scan or PET scan. Risk factors, and we already touched that because we spoke about HPV infection, and we know, and it's knowledge which is also not that old. In my textbooks, which I was using as a medical student, it was written that cervical cancer can be caused by smoking and probably also by virus, and they suspected herpes virus to cause cervical cancer. Nowadays, we take it for granted that it's caused by HPV, human papilloma virus, and it's also what makes the cervix a very unique cancer, because we know that 97% of all cervical cancers are caused by virus, so by sexually transmitted infection. And from based on this, we can also anticipate the risk factors, including sexual behavior, HPV infection, so if it's detected on the cervix, precancer lesion, smoking. For some reason, smoking probably increases the risk of persistent infection. So that the infection is not cleared from the cervix, but it persists there. And also, nowadays, no vaccination against HPV. For the future generation, there is something what is really a risk factor. And the next generation, I believe, would like to have her husbands and wives to be vaccinated, because it significantly decreases the risk of this nasty disease. Just to show you what we have recently developed, and I hope this will be used not only by physicians but also by patients. We put together really a large international collaboration of 20 large institutions and collected data for many thousands patients, and based on this, we created a model which can calculate the risk for individual patient treatment failure, and also according to the years after the treatment. So everybody can based on really simple prognostic factors, which are here. So squamous cell between 5 to 20 millimeters, grade, number of positive lymph nodes, LVSI, which is histological factor, and then SEND, and it will be available on the website. And here you can see, individual years after the treatment, what's the risk of the recurrence. So you see that the first year it's about 2%, second year 3%, and then from the fourth year it is 0. So each physician and each patient will be able to see what's the risk for individual tumor, and also what's the plan for the surveillance. So how many years she should be followed and go to the doctor more frequently. Besides risk factors, there are prognostic parameters. Prognostic parameters help us to decide about the treatment strategy. And cervical cancer, again, is quite unique in this because we know that it behaves very in a very predictable way. So we know that it grows inside of the cervix for a long time, and then if it makes some distant spread, meaning metastasis, it first goes to lower pelvic lymph nodes, then it goes to higher pelvic lymph nodes, then it spread to para-aortic lymph nodes, and then it spreads elsewhere, which is not that frequent. Endometrial cancer is different. Endometrial cancer can do pulmonary metastasis as the first metastasis or metastasis inside of the abdominal cavity, not the cervix. I remember very few cases of patients with negative lymph nodes, but some other distant metastasis. So this is why this lymph node involvement in the pelvis is so important prognostic parameters for us. And this is why we very much rely on surgical staging, meaning that we remove these pelvic lymph nodes, we send them for pathology, and we very carefully search for any type of very small metastasis. Because if this is negative, then we can be sure that there is no other distant metastasis in this disease. Classification, of course, as in every and each cancer, there are certain stages. I don't want to go into details. I don't think it's very practical. But for the definition of the management, it's important to know whether the disease is very small, below 3 millimeters, it's stage 1A, or it's bigger than 3 millimeters, but it stays in the cervix. So it still is in the cervix only, it's 1B stage, or it is the stage when it grows beside to the adjacent tissue and adjacent organs. It's already 2B stage to the parametria, or it has distant metastasis. And I will go very simply from one stage to another stage and give you a very brief overview of the basic treatment which is available for these different stages. So in case of very small tumor, so we have a tumor below these 5 millimeters, I said 3, I'm sorry, 5 millimeters, 5 millimeters. We know that simple hysterectomy, so just the removal of the uterus, or conization. So this procedure which I showed you is adequate procedure, and we don't have to do anything else. If we do conization, there is a small tumor below 5 millimeters, free margins, all the margins are free, then we are done. And we don't have to do anything else, and the prognosis is excellent. If the tumor is bigger, and here we follow the international recommendations, it's slightly more complex. So I will try to simplify it and give you the major points. So first, this is a field for surgery. So in general, the treatment is surgical procedure. We start in surgery with this one. It stands for sentinel lymph node. So we start with identification of the first lymph nodes which drains the cervix. You probably heard already about sentinel lymph nodes in endometrial cancer, might be the case. But the principle is that we inject so-called tracer, which can be color, it can be radioactive tracer, and to the cervix. And then we go from above to the pelvis and we search for blue lymph node or radioactive lymph node. So obviously, this tracer was carried by lymphatic channels into the lymph node. And we have to identify these first lymph nodes, which we call sentinel lymph nodes, take them and send for so-called frozen section, which means intraoperative assessment. So somebody runs with these lymph nodes to the pathology department, which can be next door, and can be also a few hundred meters from the surgical room. And pathologists do intraoperative, it means immediate section, and they look at it and they call you, and you are still at the operation field, and they call you and tells you, it's negative, or they tell you, yes, it's metastasis. There is a metastatic involvement. In case there is a metastatic involvement, we stop the surgery. We do not remove the uterus. We do not remove the tumor, but instead we send the patient after the sentinel lymph node procedure for primary chemoradiation. Why is it so? Because this patient with positive lymph nodes would be radiated anyway. So it doesn't make any sense to do a hysterectomy, to remove the uterus, and then send the patient for chemoradiation. So only if on frozen section, lymph nodes are negative, we continue doing the surgery. And we remove other pelvic lymph nodes. And we also complete so-called radical hysterectomy, meaning that we remove the uterus, but also the tissue around the uterus. Let's call it radical hysterectomy. And concerning ovaries, it depends on the age, but we discuss it with the patient. We can either preserve it or remove it. It depends on the decision of the patient and also on the age of the patient. Then there is another aspect, since about 40% of patients in these early stages are below 40 of age, 40 years of age. Some of them still at the time of diagnosis, they want to preserve their fertility. And this is the field which has been changed a lot, because I remember the time when I was a young physician, there was no such possibility. It was impossible to offer fertility sparing in case of cervical cancer. It could have been just 1 millimeter cancer and we remove the uterus always. So it's relatively a recent trend that under certain conditions, we can offer so-called fertility sparing treatment. And these conditions, very simply, are tumor type. So it can be these most frequent histological types, size of the cervix, negative lymph nodes, but also the location of the tumor. You see here that the aim of the fertility sparing procedure is, of course, to preserve the uterus. But as I explained at the beginning, it would not be enough. We also need at least half of the cervix to be pregnant and to keep pregnancy. So we need at least 1 centimeter of endocervical canal to be preserved. Otherwise, fertility sparing procedure doesn't make sense. So we always measure this distance, and if it's too little, if it's too small, if it's too short, unfortunately we cannot offer fertility sparing, even if the size of the tumor is half centimeter or 1 centimeter. So in another words, we can have 5 centimeters tumor, which will grow like to the vagina, no problem to offer fertility sparing. And we can have half centimeter tumor, which is located here inside of the cervix, and we cannot offer. There are different procedures for fertility sparing, but in principle, you see, this red is the tumor, and you see the red line, which is for conization. So by conization, we can remove the red tumor completely. There will be free margins, and the procedure is adequate. Now, very briefly, what are the possibilities for more advanced stages? So since now we've been discussing, disease, which is stage 1A or 1B. So the cancer is either, on the surface or inside of the cervix. But then we have, at least 60% of diseases, and this proportion between early stages and advanced disease can differ from one country or one region to another one. But advanced stages in general can be divided into 2 different situations. First one is so-called locally advanced, meaning that the tumor is extended in the pelvis. There can be even metastases, but they are only in the pelvis, usually to the pelvic lymph nodes. But still the disease is local. The treatment is not surgery, but the treatment is this, what we have here, radiotherapy. And the standard currently, of course, if the patient is eligible for such a combined treatment, is so-called concomitant combined chemoradiation, meaning that she receives not only external radiation, but also internal radiation from the vagina, so-called brachytherapy, in combination with small doses of chemotherapy. So that's why it's called chemoradiation. But chemoradiation can be effective only if the disease is again localized, because it's a local treatment. Radiation is a treatment which is focused to some region. In this situation, it's focused to the pelvis. And once the disease is metastatic, meaning that there is any distant metastasis outside of the pelvis and plus minus parotid region. I don't want to go into details. Sorry, I will just sit. So if the disease is metastatic, then we cannot use any local treatment. It doesn't make sense to do, supraradical surgery, radical hysterectomy in the pelvis when we know that there is a lesion in the lungs or supraclavicular lymph node, because this disease is the most dangerous. Although the biggest symptoms can be caused by the pelvic disease, still, we have to treat everything. So in case of metastatic disease, the only possibility is a systemic treatment, meaning chemotherapy. And currently, the standard for both squamous cell and adenoid cancer is a combination of platinum-based steroid and Taxol. So it's in principle the same chemotherapy as in ovarian cancer. Here they also asked me about some modern treatments and biological treatment. There is still, there are dozens and hundreds of ongoing studies, and we all believe that it will change within next years. But currently, we have only 2 types of biological treatment available in Europe and 3 of them in the US. First and the oldest was bevacizumab, which was approved in Europe in 2015, which is anti-angiogenic treatment. The second one is immunotherapy, pembrolizumab, which was registered in Europe and approved in Europe very recently, this year. And the third one, which is available currently or reimbursed, available is only in Europe, but reimbursed is only in the US. It's tisotumab vedotin, and this was approved at the end of the last year by FDA in the US. All these three biological treatments are approved in the treatment of these advanced cases or recurrent disease, but none of them is curative. So all three of them belongs to palliative treatment, palliation. It can prolong the interval without the disease. It can eventually prolong the survival of patients. But so far in cervical cancer, it's not that successful as in comparison to ovarian cancer and PARP inhibitors, which really changes the prognosis of patients with BRCA mutations. In cervical cancer, it's still not adequate. We are still not there. And we obviously need something more. We need probably a combination of those biological treatments for the future. So that's it. That's the overview and 50 minutes.
Hi, David.
Hi,
Sorry
Helen.
for my delay. Congratulations. Thank you very much that you support this wonderful group, and it's amazing. So I think there will be many questions. And again, thank you even that you did so many work since now, I think maybe 20 years, more than 25 years. How long?
You mean
for cervical cancer prevention and treatment guidelines? I think it's more than 25 years, I think.
It's 20 years.
Yeah, I only want to say it's not for granted, and I know that the environment is now very nice, but it was not always the same environment to bring all the different professions together. And even now, that's our new evolution, to bring patient advocacies even in the treatment decision-making process. This is, I think, the backbone. So that's only my remark. Bertha, thank you very much for your support.
Thank you, Jalit. So let's go to the questions. Are there any questions to David? Are you all silent?
Then I will just say a few words, because I remember the beginning of ENGAGE at ESGO. At that time, it was very different group, and we from the beginning, I remember that time, 15 years ago, we suffered for several years to really find the proper way how to collaborate and how to implement this patients group into the ESGO. And I'm very pleased to see that it goes on. There is an evolution, and there are new ideas how to implement patients even into the clinical trials planning, because that's an important role for the patient's organization. So I'm very pleased to contribute a little bit to your work.
Thank you so much, David. I mean, I thought it was a very good lecture. You walked us through everything and up to today and what's available today, and so it was really great. Questions from the audience? But we usually have loads of questions.
Actually, Catherine raised her hand.
Anne has a question. It says, how uncommon is it that there are metastases? And will you
Yeah, I'm sorry.
Express yourself? Okay, great, thanks.
Yeah, how uncommon is it that there are metastases and distance, like for instance in the lung, without showing any metastasis in the pelvis?
Yeah. Well, this is something what I think it's not so frequently emphasized, but really, as I said, cervical cancer is very unique in this aspect. Ovarian cancer is, of course, completely different. But in endometrial cancer, you quite often see the situation that you have advanced endometrial cancer, and then you find metastasis in the liver, or in the lungs, or in a mediastinum in the lymph nodes, or even carcinomatosis. Cervix is a very nice disease in these terms. And it behaves very predictably from the beginning. So as I said, I can hardly remember a few cases. And the question is whether we have really a proper diagnosis in the lymph nodes. But it's really something what regularly grows in the cervix. There is a disease of there might be a difference. Some diseases, of course, are faster, some slower. Some growth slow, just for a certain time inside of the cervix, and then start growth outside, and some rather expand the cervix. So you have like 6-7 centimeters tumor, and still it's surrounded by the cervical fascia. So it's inside of the cervix. But in terms of other distant metastases, it's really very predictable. It goes first to the pelvis, second to paraortic, and then somewhere else. So again, this is why we consider very careful and meticulous diagnosis on metastatic involvement of the pelvic lymph nodes so important for the planning of the treatment management. Because if the lymph nodes are negative, then we know that the prognosis is very good.
Okay, I see another question here from Icho. She's asking, what is the chance to have a pregnancy after trachelectomy?
Yeah, well, the strategy can differ here. In some countries, it can be caused by different reimbursement strategies. We see it even now that it's reimbursement of other biological treatment, which varies between US and Europe. It can vary even inside of Europe. But in cervical cancer, again, bevacizumab is used in advanced stages, in recurrent tumors. And it improves the time to progression, but this improvement is not really dramatic. So this we also have to take into consideration. There is one more aspect why we sometimes, even if we have it available, one sometimes carefully consider whether we use bevacizumab or not. One of the potential adverse effects of bevacizumab is that because it's anti-angiogenic, so it prevents the blood supply to the tumor. If the tumor infiltrates the adjacent organs towards bladder on one side or rectum to another side, and if it's a massive infiltration there, and we use bevacizumab, it can cause, with certain frequency, a fistula. So it can cause a communication between these organs and the tumor, which of course has a negative impact on the quality of life.
Okay. There's another question here also about bevacizumab, but I think you have almost answered it now. but why do some countries not include bevacizumab in advanced treatment, but only Taxol and cisplatin carboplatin? And when are patient offered bevacizumab? But I think you have more or less answered that question. Charlotte, do you want to add anything to it or ask anything yourself?
Yes, thank you, Jette. Yes, I was going to ask if vaccination avoids any chance or any type of cervical cancer.
Well, almost nothing in biology is 100%. So it applies to vaccination as well. We know that vaccine is made against certain genotypes. So there are dozens of types of HPV infection which can cause cancer, and the vaccine is manufactured only against some of them. We know that there is a cross immunization against other types, but not all of them. So there will be always some cases which will develop, even after vaccination, which are caused by other HPV types. And it's not 100%, but then what is also important is the age of vaccination. We know that the immunization is strongest if the vaccination is given at this age of 14, 15 years, 13, 14, 15 years. And it's also important that it's given before any exposure to HPV infection. And if this is done, then the effectivity is above 90%. So simply saying, you still have this 10% left.
Okay. I have one last question to you, and I think then we have there are no more questions on the list. Do you have any idea why in some women the virus clears itself, and in other women it becomes cancerous? Is there any study into that? Why is that?
This is a very interesting topic, which we don't know these factors exactly. We know that there are certain risk factors, like smoking is one, like our own immunity is one. So we know that immunocompromised women, typically after transplantation, for instance, they have very high risk of progression, and we see it. We have a collaboration with a large transplant unit in the Czech, and I can tell you that if any high-grade lesion is diagnosed at these ladies, it really goes very fast. So, but what is now a modern strategy is to triage or differentiate even amongst these women with high-grade lesions and HPV or HPV infection without lesion, to triage them, who of them is in higher or low risk for further progression. So there is a trend towards the less and less invasive. So what I want to say that even if there is HPV infection, even if high-grade lesion is found, to find other factors which will help us to stay calm and just to follow, and not to do conization, not to cut the cervix, not to do any procedure, but to wait.
Okay.
And this is the next step. This is the future, and it's already ongoing. And we have certain other tests which tells us whether under this HPV infection there are more cytologic changes which increases the risk for the cancer.
Okay. Thank you very much, David. This was very, very, very interesting. And
can I ask something just on that? Is there any clinical trials on drugs that you can take if you have DNA positive?
The HPV, you mean, I think.
Yeah, if the HPV DNA is positive.
Yes, you know, there was a big hope that since we know that it's HPV related, we know the infection, that there will be not only vaccinations for preventive measures to prevent infection, but there will be also vaccinations as a treatment, so to get rid of the infection. But these trials were not successful. So it seems that once the HPV is already implemented into the DNA of the epithelium of the cells, it's not that easy to rid of them.
Mm-hmm.
So it seems that the future strategy is not to try to, because you know, it's the same like with herpes virus. If you have it, you know, we all would like to somehow, you know, to expel it from the body, but it's not possible. It lives there, it can be hidden there for years, and then it appears if we are stressed or if we have a flu or some kind of other infection, and it is the same with the cervix. You know, against all these antivirotic drugs or everything, it can help only treat, but it cannot, you know, take it out from the DNA and then clear it completely. So the trend is what I said. It's rather to triage these patients and to really do surgical procedures only if there is very, very high risk of the progression towards cancer.
Okay, thank you very much, David. Thank you.
And can I just ask one more question, please?
That's the last one then.
Okay, sorry.
Yes, go ahead.
Okay, what is the difference? Because I think most of us, we already know bevacizumab for a long time, as you told me, but the pembrolizumab or the tisotumab, what is the difference? Is it more overall survival, or is it the quality of life, or what is the positive impact of those two medicines?
Well, the mechanism of these drugs is completely different. You know, the mechanism of pembrolizumab, it belongs to immunotherapy. So it helps the immune system to recognize the tumor, and the tisotumab vedotin is from the group of so-called ADC, antibody drug conjugates, which means that there is an antibody, and the antibody carries some toxic drug, and the antibody is carrying it through the body. It doesn't allow this toxic drug to be freed, and that's why the systemic effect is much lower, but it goes somewhere to the cancer where the antibody is attached, and only after this binding in the cancer, it frees this toxic drug. So those are completely different mechanisms. It's difficult to compare and to say, you know, BEF is better, or this is better, or that is better, because the populations in those trials were not the same. We cannot say it's the 10%, it's 15%, it's 7% here, because then you would have to compare it directly. But you know, it gives us a different mechanism, and in the future we see that if we want to really make change, we will probably need to combine these treatments, and that's why the ongoing trials, which are recent trials, are trials which combine 2, 3, or 4 treatment modalities. The question is, of course, as you mentioned, toxicity. You know, what will be the negative effect of these drugs, and yes, I agree that many of those patients with advanced cervical cancer, specifically in cervical cancer, are diagnosed really at a stage where they suffer from bad kidney functions, they simply are not in a shape to receive such a toxic, potentially toxic treatment. But for those who are in a good performance status, this will hopefully be the future.
Okay, thank you.
Thank you so much. Thank you so much. I think no more questions because the time has passed. And thank you so much, David.
Okay, thank you for your time. And Jalit, it was very nice to see you.
Yes.
Thank you very much. Thank you
Yes,
very much.
no, and hopefully we will see in Chicago. Yes, we will see.
I'll be there. Yes.
Yes, wonderful. And again, this is really, I think, one of the milestone initiatives from ENGAGE and ENGOT and ESGO. So it's really impressive. Even the question, it's not different to doctors. It's a different way, but it's always the same question. So it's wonderful that we find together some solutions we are looking for.
Thank you.
So
Thank
when
you so
are you
much.
going to Chicago?
The first week of June, I think.
Oh, it's in ESGO then.
Yes.
It's ESGO, yeah. Okay. Yeah. Okay. So I just want to say to everybody else, please remember to let me know if you haven't already done so, if you're going to Berlin on the 17th of August, because Jalit and I need to know. Okay. Yeah. Thank you so much, everybody, for joining today.
Thank you.
Have a nice day.
Thank you.
Bye-bye.
Thank you.